Good afternoon, everyone. Thank you for joining us today. We apologize for the delay, but we appreciate your patience. This webinar is supported by Horizon Therapeutics, and we thank them for their support. My name is Molly Alawade, and I am the Director of Education here at the American Kidney Fund. Because today is National Gout Awareness Day, this webinar will focus on gout and kidney disease. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel you should see on your screen. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the section of your control panel titled Questions. We'll see your questions and we'll do our best to answer them, either by replying to you in the questions box or out loud during the last several minutes of the presentation. This webinar is being recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. For those of you in attendance who are health professionals, we are glad that you joined us today and hope you'll recommend this webinar to the patients you work with. However, as a friendly reminder, this webinar is not accredited for continuing education credits. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. Without further ado, allow me to introduce today's speaker, Dr. Christopher Parker. Dr. Parker is a rheumatologist and an esteemed professional speaker and educator to physicians. Dr. Parker is also the medical advisor of the Alliance for Gout Awareness. He is board certified by the National Board of Osteopathic Medical Examiners and the American Board of Internal Medicine. Dr. Parker graduated as the valedictorian in his medical school class at the University of Health Sciences College of Osteopathic Medicine. He performed his fellowship in rheumatology at the Walter Reed Army Medical Center and the National Institutes of Health in Washington, D.C. Dr. Parker served on the teaching faculty during his years at Walter Reed and Brooke Army Medical Center, where he was recognized as Teacher of the Year twice. Dr. Parker's work is published in several medical textbooks and medical journals, and he continues to be involved in clinical research and teaching. Thank you, Dr. Parker, for joining us.
Well, you're absolutely welcome, and thank you all for waiting a minute while I was taking care of patient care so I could, be unobstructed while we were going over this talk. I'll also mention by way of introduction that I love speaking and teaching on gout. It's an area of special interest of mine. I take care of tons of patients with gout and absolutely love helping them with their condition. So this slide deck I'm going to walk through, but my goal as I do it is to really make the condition easy to understand. Of course, I want you all to feel comfortable about what causes gout, how do we diagnose it, and then of course moving on to therapy. I'm definitely going to leave time for questions, but because I've given many lectures through the years, I anticipate the types of questions you might ask, and so I'll be covering the things that I am expecting to be asked about as we go through, most of which people want to know, well, how do I treat gout? How do I fix it? And so I'll spend quite a bit of time on that particular topic. People also want to talk some about diet, and I'll cover some of that stuff as well. Next slide. I'll say next slide as we go because I'm not controlling that. I apologize if that bothers anybody. So I'll start by saying I love these pictures here, especially the one with the, I'm going to call it the devil or the dragon on this person's foot, so I can explain that this is a visual interpretation of what gout feels like. And what I try to get across to people who have not had it before, and many of you listeners, I understand, are listening because you have a friend or family member or a loved one with gout, and you're trying to understand what's plaguing them, if you will. And gout is a exquisitely painful condition. And so I remember taking care of a soldier when I was in the Army who was explaining to me, he was a foot soldier. This guy was a infantryman, so he literally kills people for a living. I mean, this guy is tough, and he was explaining to me that he had been shot before. He'd passed a kidney stone. He'd taken shrapnel, and that stuff was, to use his words, a Sunday picnic compared to having a gout attack. So this thing is a beast. And I like to have the other picture here to help you and really all of our listeners know that even though people think, oh, gout only affects the big toe or only affects the foot, that's not it at all. This person has terrible accumulation of uric acid, which causes gout in their hands, and you can see these big nodules. So you can clearly understand when you look at this that it can get into any joint in the body, any joint, not just the feet. So next slide. And I'm going to now transition to, that was introduction. How do we get gout? And I'll start by saying uric acid is a normal waste product. I want to really feel good about that. It's not like uric acid is weird. All of God's creatures make uric acid because we eat, and therefore we have to break that food down into usable products and waste products. And one of those waste products is uric acid. So all of the animals make that. But some people, because of, it could be many reasons, either what they eat or how much they eat, but very commonly, if one of the most important organs in getting rid of uric acid is sick for any reason, and that's the kidney, it can build up. It can build up. So the kidneys they have a very big job, as many of you listeners know, and the kidneys are in charge of lots of things, fluid status, and getting rid of many waste products and balancing many electrolytes in our body like sodium and potassium and chloride. And one of the things the kidney tries to get rid of is uric acid. It's a waste product. But if your kidneys are sick, that uric acid can build up. And if it builds up enough, that uric acid can deposit in skin and under the skin and in joints, and really can get into any organ in the body. And as it accumulates, it can result in these periodic horrible flares that I mentioned earlier. And so this slide, highlights that 1 in 10 people, so literally a full 10% of people that have kidney disease have gout. And it's also, I want to spend another second on this slide sharing that there is this false belief that women cannot get gout, and that's completely untrue. It's completely untrue. It's more common in men than women. That is true. And the reason that is because while women are making estrogen, so in their childbearing age years, that estrogen helps the kidneys get rid of uric acid. But as a woman goes into menopause, those estrogen levels fall and the uric acid levels rise, and then they can get caught up. They can get gout too. But if even a young woman has kidney problems, then that benefit of estrogen goes away. And as the kidneys get sicker, that uric acid can build up, and then they get into the same club as the men with gout. So I want to dispel that myth that women cannot get gout, even young women. They certainly can in this situation. Next slide. So gout is often called the disease of kings and the king of diseases. And many people are under the impression that it's the disease of kings because only rich people can get gout. Rich meaning they're wealthy enough to indulge in expensive and good foods and drinks. And many of my gout patients only wish that were true, meaning they wish they were rich, and that's how they got gout. But the fact of the matter is anybody can get gout. If you just have to be a person that lives on Earth and accumulates uric acid either because of sick kidneys or some other medical problem, or just by being male or having a genetic background. Some families really have lots of gout, and it's just in their genetic background. Here are some famous people that have gout. Gout's a very common illness, though. More than 8 million people in the United States have gout, so it's a very common illness. In fact, for men, it's the most common kind of arthritis once you get past normal wear and tear. And then, as I mentioned, women can get caught up with men as they get older, as the estrogen levels fall, and particularly if they have sick kidneys. Next slide. So how do we diagnose gout? Because there's lots and lots of kinds of arthritis. And so what I do, and the most important thing I do in that regard, is I listen to patients. and I listen to them. And if they're having intermittent flare-ups of very painful arthritis, of course, I start thinking, oh man, good, this could be a gout problem, right? So the history and physicals, one of the most important things. And then I try to build a stronger case if I'm suspicious for gout by asking about family history, trying to see if it really runs in this person's family. And then I use laboratory studies, meaning blood tests, to help me build an even stronger case for gout. And I'll say that I do two things in that regard. I look for and do labs for not only checking uric acid levels, but I want to check for other things that can look like gout in the lab. And so if a patient starts looking like they might have, it could be gout or rheumatoid arthritis, because this person has lots of different sick joints, then I might do labs to rule in or out one of those disorders. And so after I do all the lab studies and history and physical taking and any imaging, meaning x-rays or maybe even MRI, I gather all that data up and I say, this person either does or does not have gout. And if there's any doubt at all, I'll actually put a needle in a sick joint and pull that fluid out, and I'll send it to the lab to look for those gout crystals. This picture actually shows somebody that has a cut, and under the skin, that skin right underneath that white chalky stuff that comes out is gout. So remember, it gets under the skin, it can get in joints, it can get in any organ. And if I'm worried that someone has gout and I just can't tell by the lab and x-rays and history and physical, then I need to know, and I'll put a needle in there and pull the fluid out and look for gout crystals. Now, happily, if you're wondering how often you have to do that, the answer is not very often. Usually with just history and physical and basic studies like lab and x-ray, I can figure it out. Next slide. So what do gout crystals look like under the microscope? I love this slide. And here on the left-hand side, it's got a magenta background, and that's because we've kind of made the microscope lighting look like that so the crystals can pop right out and you can see them. Here, they're two different colors only because, well, it's complicated optics that make them be either yellow or blue. But what I really want to highlight here is not so much the color, is I want to highlight the shape, right? So when people say they're needle-shaped, they're not making that up. They really do look like little needles here. And if you can envision, thousands and thousands of these little needles in your joint, what I want people to know is that even when you're not flared up, these little needles are there, and they're putting excess wear on the joints. When you try to walk around and do your daily life, you don't want excess wear in there, grinding down that cartilage. So gout is really, when you look at this picture, it helps you understand that it's really, there's two problems that you have when you have gout. Number one, you have these intermittent, horrific, painful flare-ups, but also, even when you're not flared up, you have this excessive wear happening on your joints, grinding them down over time. And it can cause destruction of joints, every bit as destructive as rheumatoid arthritis over time. So I like people to understand that this is a chronic illness that you definitely want to tend to and treat so you don't have those problems occur. And on the other side, I have a picture, not of gout, but a whole bunch of white blood cells. And in the middle, you look at one of these white blood cells and you have these little red dots in one of the cells, and those are bacteria. And so I oftentimes use this picture when I'm teaching other physicians and nurse practitioners and physician assistants on gout, so they can recognize that during a flare-up, this gout attack is so inflamed that it can look exactly like an infected joint. And this is a picture of what an infected joint would look like under the microscope, meaning you'd see these little bacteria in the white blood cell. And you can't tell if you just look at somebody's foot or look at somebody's elbow, but you'll just see a hot, red, swollen joint. And so I tell doctors that if you're worried this person has an infection, like say they're in the hospital for pneumonia, and you can't tell if it's a gout attack or infection, the only way to know is to stick a needle in there, pull the fluid out, and see either crystals, which you can see on the left side, or bacteria in the fluid, which you see on the right side. The treatment is vastly different. So sometimes you absolutely have to know, and this slide hopefully drives that home. Next slide. And I'm going to reiterate using this slide that the only way to make a firm diagnosis, meaning 100%, I know for sure this is gout, is you pull that fluid out of the joint, look under the microscope for these crystals here. Again, they're colorized by either appearing yellow or blue. In real life, they're not that. It's just the way we have the optics set up through the microscope. In real life, if I look under the microscope, it looks like this middle panel here, where there's a needle shape right through a circle, and that circle is a white blood cell. So here the white blood cell has gobbled up one of these crystals, and it's almost poking right through the thing is what I can see here. And on the far right, you see that a little bit better because we have the microscope light shining right through the crystal to kind of make it bright, so you can see that crystal that's just about the length of a white blood cell here, or kind of cutting right through the diameter of it. So that's what it looks like in real life. With it's not colored yellow or blue. Next slide. Now I'm going to start transitioning. All that's really background. I'm going to start transitioning to treatment. And this was a advertisement that I saw in a magazine one time about, treating gout, because the darn thing looks like, that looks like it hurts to me. And so I'm going to start talking about management. Next slide. So in my simple mind, when a patient sees me for gout, I have several goals of therapy. First and foremost, if somebody has a flare-up right now, I don't have to convince you that what the patient wants and needs is to get that flare-up, that pain, stopped right now. Forget about everything else. You need to get that flare-up stopped right now. It'll change your priorities when a gout attack is happening. And then once that's done, I have several other goals of therapy that I want to achieve. One, of course, is to prevent future flares. These things are no fun, and they oftentimes occur in the worst of all times, like when you're on vacation or an important holiday or something like that. So we want to prevent. We want to prevent that joint damage that I mentioned before. And very importantly, I want to prevent that uric acid accumulating in other organs and damaging them. We've talked about the importance of the kidneys. The kidneys are the most important organ in getting rid of uric acid in the body. 2/3 at least of uric acid is eliminated through the kidney, the other third through the bowels. But that uric acid can accumulate in the bowels, it can accumulate in the liver, they can accumulate in the brain, in the lung, anywhere they can accumulate. So we want to prevent damage in any other organ at all. And I say improved quality of life for sure. Whether or not it's going to improve length of life is debatable, but certainly quality of life. So all those things are on my mind. And here's some pictures of the kidney on the bottom here. Next slide. So going back to flare-up, this is a slide I like to share with doctors so they can understand the tools in the toolbox to stop a flare-up. On the left-hand side, in my simple mind, since this thing is so painful, I think about, well, what medicines do I have to treat pain? And many patients, if they don't have sick kidneys, will use anti-inflammatories. That's the non-steroidal anti-inflammatory drug. So that's like Aleve or Advil or Motrin, some kind of thing that you might use over the counter. And if it's horrendously painful, as I mentioned, sometimes it really is, comparative to, I had women tell me it's like childbirth, natural childbirth or something like that. I would say, well, gosh, they might need a really strong pain medicine, hydrocodone or tramadol or something like that. So I have all these tools in my toolbox for pain, but these don't control inflammation adequately to get that swelling and redness and heat down. And so on the right-hand side of the slide, I have anti-inflammatories listed. It turns out that these non-steroidal anti-inflammatory drugs, the naproxen family and ibuprofen and all that, they are anti-inflammatory as well as anti-pain. So they're oftentimes used, but if they're not enough for a patient, steroids, which you see second here, are by far more anti-inflammatory. They're not pain drugs, but they're powerful anti-inflammatories. The bigger the dose you use, the more anti-inflammatory they are. So many doctors will prescribe oral steroids, meaning by mouth or pills, Or you can inject it. You can inject it into a joint. You can give it IV. You can give it kind of give somebody a shot in the behind. You getting those steroids in there, it can very powerfully get that inflammation under control. And lastly, colchicine is a pill that's also anti-inflammatory, and it's been known about. It's made from a plant for more than 1,000 years. Some people say it's 16 to 1,800 years ago. There's some debate on that, but the long and short of it is, what doctors from antiquity notice is if you grind up this plant, and as soon as you get a gout attack, you take it, you can stop an attack. It does not lower uric acid. It just works on the inflammation. And so I like to organize a plan if patients have gout, not only what I'm going to give them on this visit, but if it works good, in the future, I want them to always have something around at home, and if they travel, take it with them to stop flare-ups from happening very quickly so they don't miss out on vacations, other fun things. Next slide. Now, next, I want to talk about prevention. So let's say whichever therapy we use, and again, you have lots of tools in the toolbox, you and your doctor, to control the flare-up. Once that flare-up is gone, we want to think prevention, right? That's very, very important because you want to get these things to stop occurring and then never come back, right? So the first thing I do is education, like you and I are doing right now, and I applaud you all for listening in. So I talk about, what things we can do to prevent. I look at people's medicine list and see if any of those, increase uric acid. And I explain, like I'm doing right now, what causes gout. All that stuff is very important. And there's some data that it can be helpful. There's I also make mention right here that many patients who have gout, they don't know their uric acid level, which to me is a crime, right? If you have diabetes, you better know your blood sugar. If you have high cholesterol, you better know your cholesterol. And in my mind, if you have gout, you better know your uric acid. Check your blood. If you don't know the results, ask your doctor, hey, I need my uric acid checked. I'm trying to manage my gout, right? And patients going on the diet, they all want to know about diet. What do I have to eat, or what do I have to subtract to stop having attacks? And I say, well, the first thing I want you to know about diet is this, and that is human beings that live on Earth, at least from what I can see, are even if they're Olympic athletes and they have a very austere diet, they fudge it sometimes, right? So if you're thinking, well, is there a diet that is likely to result in control over the long term? The answer is no. No, diet is not a great strategy for long-term success because it's very hard to have an austere diet all the time, meaning a difficult one. So when I start telling patients, at least in Texas, we really need to cut back on alcohol, I don't even tell them zero. I say cut back. It's like, good luck, right? Weight loss can help. I tell them that diets that are really high in purines that get broken down to uric acid are things like organ meats, which a lot of people say, I don't do that anyway. And I go, well, shellfish though. So that's shrimp, that's lobster, that's oysters. And they're like, oh man, I like those. I go, yeah, I do too. So I tell them about diet and I give them the things that are really high, like alcohol, especially beer, and shellfish and organ meats and stuff like that. But I say, listen, you're much more likely to be successful if you do diet with medications. So that way you don't have to have this strict diet all the time. And that's how you be successful. And I have, hundreds and hundreds of patients who are successful that way. My people that would try diet alone, over time, they're not successful. And they learn that. So the other thing I think of is if somebody's on a medicine that increases uric acid, what if we just got rid of that? That'd be great. So many patients, if they're on aspirin, that can increase uric acid. And some patients just take it just because. The doctor didn't tell them. They just said, man, I think I should be on aspirin, right? I go, no, you don't have heart disease. Why would you need it? And so I get rid of that, and that can be helpful. Same with hydrochlorothiazide. This is the abbreviation for a water pill. And some patients get put on that for blood pressure, but other blood pressure medicines might work. And so we get rid of that, and it helps a lot. So I didn't add anything. I just subtracted. Another thing I think of is, say somebody has high blood pressure and they need additional blood pressure medications. I think, well, what if I could use a blood pressure medicine that also lowers uric acid, meaning go for 2 for 1? Then this medicine, losartan, that actually does both. And so I think about that kind of stuff. All of these things cross my mind. And then if these are inadequate, Then I have medicines that all they do is lower uric acid, which I'm going to cover on this next slide. So go ahead and go to the next slide. And what you'll see now are the medicines that are used most commonly to lower uric acid. Okay, and of those, of the ones that are on here, the most common by far are going to be allopurinol and febuxostat. Okay, that's going to be your bulk of it. Some probenecid, sometimes probenecid. I'll explain how these work in a minute. And then lesinurad, I think, is now off the market. But what I've done is on this slide, I've organized it. So on the left-hand side are medicines that help your kidneys get rid of uric acid. Help your kidneys get rid of uric acid. That's why people say drink cherry juice, because it does help your kidneys excrete uric acid a little bit. Any vitamin C or any citrus juice would do that. And it doesn't have to be cherry juice because it has vitamin C, and vitamin C does that. But I want to highlight that for this form, again, many, if not most, if not all of the listeners have kidney problems. And so it's just because of the nature of this particular talk and this audience, you have to have good kidneys to get these particular medicines to work, probenecid and lesinurad. And so for that reason, they're not used with any great frequency in the United States. Now, that gets me to the right side. So these ones do not require, or they're designed to not help your kidneys get rid of uric acid. They work differently. What they do is they inhibit the enzyme in your body that makes uric acid. So when you're on one of these pills, you'll make less. You'll make less uric acid. Right? That's how these top two pills work. And so allopurinol has been around a long time, almost 50 years now, and so that's a once-a-day pill. It's very inexpensive, and it's oftentimes used to start with. If, however, it doesn't work well enough, or you have to have decent kidney function, because when you break allopurinol down, you need kidneys to get rid of some of the breakdown products of allopurinol. And so if the kidneys are so sick that you can't use allopurinol, febuxostat, also known as Uric, is a backup drug. Now, it's currently still a brand name product, but it should be going generic in the very near future, meaning the next number of months, and hopefully that'll drive the price down. And so this is commonly used in the population of people that have kidney problems, because it does not require adjustment in people that have sick kidneys, and it's a very effective therapy. So these are the commonly used pills. But what if somebody, in spite of having these pills in the toolbox, is still can't control uric acid? So my strongest and most powerful medicine for lower uric acid is an IV infusion medicine called uricase. That's the generic name, or pegloticase. Uricase is an enzyme. Pegloticase is the generic name, and Krystexxa is the brand name. So the way that one works is the enzyme in our body that we don't have that breaks down uric acid, I can infuse that, meaning start an IV and infuse this protein into your blood, and it will quickly break that uric acid down. So if I check that uric acid tomorrow, it might be so low it's undetectable. And what happens is the uric acid that accumulated in your body over years will rapidly start dissolving. And so I can fix a uric acid problem, the uric acid burden in somebody's body, in months with this IV infusion, which would take years to do the same thing if I was using a pill. So my sickest patients are often given this medication so I can really clean house in a short period of time, and then get them to a pill to maintain that. So that's kind of all my tools in the toolbox: uric acid lowering, and then before that it was the controlling pain and inflammation. Next slide. Go ahead and go to the next slide. Yeah. Okay, beautiful. So this is a recap of things that we just talked about, because this is the most commonly used drugs, I should say, the pills in the United States here. So again, allopurinol, and it highlights some of the basics here. Not expensive, again, generic, been around a long time. Does require renal adjustment for safety. That's a big important thing. And as many as 50% of people, in spite of using this, don't get that uric acid under control. So we have this drug, again, currently it's still a brand name product, so it's more expensive. It does not require adjustment in people with sick kidneys. So that's a big advantage. It's stronger. It's more likely to be effective. That's an advantage. There's some data that can stabilize people's kidney function if they're hyperuricemic or if they have high uric acid levels. Those are the main things I want to share here. Next slide. As I mentioned previously, if my pills don't work or somebody's very sick, here's a picture of somebody that has so much uric acid, you can see it right under the skin. It looks chalky and white. If I were to poke somebody's skin and have it ooze out, it's kind of like toothpaste to me. So it just kind of oozes out. And one of the problems with that, if it's this bad, is it makes it very hard for the skin to close up. And so that wound will stay open. And then if that wasn't bad enough, if it gets infected, it can be very, very hard to treat. And some people actually get, toes or foot amputated if they can't get an infection cleared up. So when somebody has very, very bad gout, I start thinking about using my very best medicine, as I mentioned before, pegloticase or Krystexxa, because I really need to get that uric acid under control as quickly and appropriately as possible, and then I can switch to pills after that. All right, next slide. So this slide highlights one of the most important things that I want you all to take home. And I've mentioned it before, but if you're a person who has gout, you do not want to guess what your uric acid is, okay? You need to know, right? So just ask your doctor that you're working with, or ask your nurse practitioner or your physician assistant or whatever. You can even go to a lab and check yourself. But you need to know that number, because if your uric acid level is always being over 6, or even sometimes being over 6 milligrams per deciliter, that's too high, right? So I want all my gout patients to consistently get that uric acid below 6. And I tell them the sweet spot is between 2 and 6. And if you stay in there, eventually you will quit having attacks, and you can preserve those joints from getting, worn out and damaged over time. So you absolutely have to check. So that's where the money is. That's why I have that picture here. The money in treating gout is knowing your uric acid level and acting on the information. The other reason I have this picture here is Benjamin Franklin had gout. So it's kind of a 2-for-1 slide, or 2-for-1 picture. So you check it at the lab. There are ways to do home monitoring now. So just like diabetics check their blood sugar at home, that can be done at home as well. But I definitely think that at least sometimes you're going to want to check with your doctor, so you're both on the same sheet of music and you are acting on the information. Because if they don't know your uric acid level is elevated, then they can't help you get that under control. Next slide. This is a picture of one of those home uric acid monitoring tests, and it actually has a 6.0 there, because that's you want it less than that. It's kind of your goal, less than 6. But this is one you could do at home. It's pretty easy. Just like diabetics do, you poke your finger and you put the blood on the test strip, wait 30 seconds, and then it tells you your number. It's pretty easy, and it helps you keep track of it. Not expensive. I think they're like, I don't know, 50 or 60 bucks, something like that. Next slide. So now I'm going to just do a wrap-up of the whole talk. I mentioned earlier that gout is a very common problem, and it's very, very common in the world of kidney disease, no matter what kidney problem you have, because your kidneys are the most important organ in your body that gets rid of uric acid. So naturally, if your kidneys are sick, that uric acid builds up. When that happens over time, you'll get these intermittent painful attacks. They're very painful. I mean, they're horrendous. They wake people up out of sleep, right? And the good news, though, that I hope that you all take from this is you can check your uric acid and act on the information, right? If you're not checking, you are playing with fire. It's like rolling dice. But one of my patients says, and I actually include it here because it's so valuable, is, here's the message of hope. Either you manage gout or it manages you. And it manages you big time when you have an attack. You can't do anything. And if you have a toe on one side and a knee on the other, you're in a wheelchair, right? But the good part is, look at the first part of the sentence. You can manage it. And if you do, you can make it so it never flares up. You get under control and then it never flares up. This thing is manageable. So the take-home message for the whole talk really is one of hope, right? You can fix this thing. So what I'll do next slide, and I think we now have time for questions. I'm going to reiterate how happy I am that you all listened in.
Well, thank you so much, Dr. Parker, for joining us and for this excellent webinar. So at this time, I'd like you to answer a few questions that we received over the course of the webinar.
Yes.
So here's the first question. So is gout a form of arthritis?
Yes. And let me expand on that. I'm going to give the short answer is yes. And the larger answer is arthritis just means inflammation. That's the itis part. And joint. So arthro means joint. And itis means inflammation. So inflammation of joint. So yes, remember those crystals get in the joint. And then even when they're not flared up, it's causing excess wear and there's inflammation in there. And then when it flares up, you have tons of inflammation. And so it's definitely a joint inflammation problem.
Great. Well, thank you for that great explanation. So here's our next question. As a double below the knee amputee, I take hydrocodone for phantom pain. Could this increase my risk for gout?
I'm processing that. So I am very familiar with hydrocodone and other opioids, narcotics, that kind of, those strong pain medicines. And as far as I know, and I'm very knowledgeable in this area, I do not think it's going to increase uric acid or increase your risk of getting gout. That medicine is not a risk factor for gout. I have never seen any cases, no literature or anything like that. I think you should not worry about that.
Okay, that's good to know. So our next question is, are there benefits to prescribing colchicine daily for management over allopurinol?
Yes. Okay, that's a good one. So the short answer is yes, but I want you all to understand why. Okay. So I mentioned earlier that colchicine works on inflammation and does not lower uric acid. That's very important. So if we only use colchicine to manage gout, we will never fix the root cause, and you can still get damage. But if the colchicine works wonderfully, you'll quit having flare-ups. Now, if you quit having flare-ups, you might think, oh, I'm in the clear. But you'd be wrong if you thought that. Because remember, that uric acid is still accumulating in your body, still accumulating in your joints, still getting in organs. And so you can damage things unless you get that uric acid down. So what I do, not uncommonly, if somebody's having frequent attacks, I mean, what if you're having attacks before you see me, you're coming in like, Doc, I have gout attacks every few weeks. And I go, man, that's horrendous. And if I know it's probably going to take me months to get that uric acid under control, I will frequently use both. I'll implement the colchicine right out of the gate. I want to get those flare-ups to stop happening. Now, all of a sudden, we're not in a rush. And then I can implement allopurinol or febuxostat, or even if I'm using my strongest drug, the pegloticase, that IV drug, Krystexxa. Once that colchicine is in there, then I have time to get that uric acid under control without these flare-ups, or the flare-ups become minimal, and then I can go down the road more, so the patient's more comfortable. And then once that uric acid is under control, I like to say that once the house is clean, then I can take that colchicine away and just keep the house clean with whatever uric acid lowering medication I need to keep it clean. That makes sense.
Yes, that definitely makes sense. All right. So I have an interesting question for you next. What do you think about the usage of celery seed for treatment of gout?
Yeah, I'm glad you asked that. Like, actually, it's interesting and pretty common. And I'm going to amplify what I said earlier about diet. So there's lots and lots of what I'm going to call natural products out there that are either suspected to or in theory will lower uric acid and help prevent gout. And so what I tell patients is, listen, celery seed, great, go ahead, put that in there. If you want to drink cherry juice, that's great too. There's data out there that says if you're a milk drinker, that helps lower uric acid. There's actually some science behind all these things. But the fact of the matter is, if you do that stuff, and you don't check your uric acid, you have no idea if you're going to be successful. So, but the flip side is also true. People, yeah, I'm using celery seed, and I'm drinking cherry juice, and I'm wearing a copper bracelet because I think that works too. And nowadays I like to take some cumin, or no, it's let me see, one of the other spices that temporarily forgot it. And I'm doing all this stuff, and I check my uric acid, and it's always, in the low 5s. I go, great, keep that up, beautiful. Because I don't want you to have to guess. So I'm totally fine with using natural products. And again, they can provide some help, but I wouldn't do it without checking, because then you just do not know. Hopefully that makes sense to everybody. I really want to reinforce that, because I run with one of my patients, I run something called the Gout Support Group of America on Facebook. A lot of people get their information from stuff like Facebook, right? And patients all over the world, in the English-speaking world, are members of this thing, and they all want to do these natural things, but not check their labs. And I tell them, guys, that's a bad idea if you don't check your labs, because then you can still have flare-ups, and you think you're doing fine.
Well, while we're on the topic of natural remedies, we have some more questions from the audience. So what do you think about treating gout with baking soda and water? And if somebody were to use vitamin C, how much would they have to take for it to make a difference with their gout?
Got it. So let me do the vitamin C one first. So again, there's some good science out there showing with confidence that vitamin C does lower uric acid, and so it's not a myth that cherry juice and grapefruit juice and orange juice can lower uric acid, because again, they're citrus fruits, right? And so if I say, well, listen, if you don't want to drink juice and you just want to get that benefit from vitamin C, then I'll do like a 500 milligram tablet 3 times a day, or 1,500 milligrams a day appears to be adequate for getting that benefit. And how much benefit you might get is, again, don't guess. Check your labs and see how much benefit it gives you. But in my clinic, on average, it gets me about 0.5 milligrams per deciliter of lowering effect. So if you were at 7, let's say, and I put that in, then now you're at 6.5. So you're very close to getting that under 6. You really want to be under 6 all the time. If you were 6.2 and you got it and you did that vitamin C, and now you're down into the, 5.7, 5.8, you're being real consistent, I'm going to say, great, you don't need to do anything else. You're there. Let's just keep an eye on that thing periodically, checking your labs and making sure it stays, because if it drifts up, I want to do something else. I don't want you to have flare-ups. Now, regarding water and baking soda and other over-the-counter natural remedies, same thing as vitamin C. You can do that stuff. And if it's effective, meaning it controls your uric acid, go ahead, drive on. If it's not effective, I want you to act on the information, act on the data. Don't guess. I think hydration is important for anybody, especially if they have kidney disease, right? Because we want the kidneys to be nice and hydrated to work as good as they can make. So feel free. And there's people who are really knowledgeable about. Here's where we do a little chemistry here. So saturation points are impacted by pH and temperature. And so you could go, wow, maybe I could change my pH by using baking soda and change the saturation point of uric acid in blood to help me with my gout problem. I'm going to say, well, good luck on that. It's probably not going to change very much, but even if you're successful at changing your pH in your blood, more importantly, you need to change your uric acid level. Check it, and then you don't have to guess.
Well, that's great advice. So our next question is, what kind of over-the-counter medicines for pain would you recommend if NSAIDs are not safe for a certain patient? Yeah,
so the question is, what kind of over-the-counter what kind of over-the-counter pain medicines could I take? What was the last part of that?
If NSAIDs
or just that was it?
Yep.
Oh, if they're not adequate. Right, so the over-the-counter medicines in the toolbox are NSAIDs, meaning the naproxen and ibuprofen kind of medications. Aspirin, of course, is over the counter. They all kind of fall into the same category of anti-inflammatories. So many people can use those successfully. Again, in our population where we're really being careful with kidney function because of kidney problems, we are usually the nephrologist says no on those. There's a big X on those. And so I go, oh man, okay, well then I've still got Tylenol, which is acetaminophen. It's a pain drug. Remember, it's not anti-inflammatory, but it's not, but it's for pain. So that could help. That could help. And I would say, I don't know of any other pain medication that's really going to put a dent in gout pain because it's so darn painful. I would say if Tylenol doesn't work and you can't use the NSAIDs, you're probably going to want to talk to talk to your nephrologist or one of your doctors, so that way you could get something else for pain, meaning something stronger than that. So in my mind, going up the ladder, you got tramadol, Tylenol with codeine, hydrocodone, going all the way up to morphine. There's lots of options there if your doctors are comfortable using those drugs, just temporarily while you're having a flare-up. I mean, hey, this thing hurts. And then we have medicines that are just treating inflammation. And again, many doctors will use steroids. Remember, they're prescription, but they get that inflammation controlled so fast that pain goes down rather quickly, and then the patient is happy. Like, yeah, I don't need those medicines because the inflammation is controlled. So steroids are commonly used in people with sick kidneys because it doesn't impair kidney function. The downside, though, if you also have diabetes, those steroids really mess up blood sugars. So be careful if you're also diabetic because it really dings that up. And then, of course, colchicine is anti-inflammatory and can be used also good. But again, that's by prescription. So I'm sorry to go back to prescriptions because you asked me about over-the-counter, but our options are limited over-the-counter. And this thing hurts too bad to be messing around.
That definitely makes sense. So here's an interesting question. Does kidney disease trigger gout, or does gout trigger kidney disease?
I'm going to answer the question this way. I think that the situation is people that get sick kidneys for any reasons, that's a big risk factor for gout. I'm going to amplify that. And I realize it's possible to go the other way, but I think the most likely thing for the majority of patients that find themselves with sick kidneys and gout is it happened in that order. I developed some kind of problem that impaired kidney function, and my kidneys have a very big job to do every day, one of which is get rid of uric acid. And that uric acid over time built up, and then I started having gout troubles. And so now you have, the combination. Now, uric acid, just so we're all on the same shit in music, is a type of salt. Even though we say it's uric acid, it is a type of salt. And that's why those are crystals. When you look at them under the microscope, they're gout crystals. And so those crystals, they can crystallize in your kidneys. They can make even a kidney stone. So I think sometimes it does go the other way. Somebody has such a bad uric acid problem that they not only get gout, but it impairs kidney function because they get kidney stones and they get those crystals to crystallize in the kidneys and impair function. But I think that's the less common scenario. Both can happen, but one is more common than the other is probably the best way to answer it.
Okay, that's a great
Hopefully that
explanation.
helps.
Definitely.
I'm not trying to make everybody, confused, but the world is complex, and so I think it can go either way.
Yes, absolutely. So our next question is, can you have gout but not notice symptoms?
Yeah, I love it. I love it that you asked that question. So amazingly, the answer is yes. And let me amplify that. So the great majority of the time, patients figure out they have gout because one day, without any trauma, all of a sudden they have pain that really hurts in like a toe or a foot or an ankle or a knee. They're like, what the hell? Last night I felt fine, and this morning I can barely walk. Right? They don't know it's gout yet, right? They have to do all these studies and figure it out. That's the more common situation. But amazingly, every so often, someone will see me that have never had a flare-up. And the way it was found, it was incidental, meaning they were getting checked out and treated for something else. They might be seeing a podiatrist, and they have this bunion problem. And the podiatrist started working on that bunion, perhaps in the operating room. So they cut in there, and they're trying to fix a bunion. They go, what? Look at all this gout, right? And so they get all closed up, and the doctor will tell the patient, yeah, I fixed your bunion, but did you know you have gout? No, I never knew that. Well, you need to see a rheumatologist. You had all kinds of gout in there. What the heck is gout? Well, you better talk to your rheumatologist and find out. But it's a type of arthritis. So every so often that happens, or they see an orthopedic doctor because they're getting a sports injury fix, say an ankle problem, knee problem, shoulder problem, or something like that. And the sports medicine doctor puts one of those scopes in there, and they're fixing up ACL or a meniscus problem or something like that. And they get out of there, and the doctor says, you know what, I fixed your ligament problem or your meniscus problem, and oh, by the way, you got gout. Right? So they never had a flare-up. Now, I think eventually they would, but every so often it's found incidentally. That's the uncommon one. No, I want to stress that. Isn't that fascinating? That's why this stuff's so fun to listen to and learn on, and very fun for me to take care of, because it doesn't go the same way all the time. It's not predictable.
Wow, that is fascinating. So our next question is, will joint swelling eventually go down if uric acid is under control?
Yeah, the answer is yes. Yeah. Once you, again, I like to use the analogy of cleaning house. So if somebody's using a medicine to get that uric acid down and get it less than 6 all the time, then those crystals start melting away, just like rock salt in distilled water. It'll melt away even if you don't stir it. In the same case here. And so if that joint or joints are sick and swollen because of uric acid, and you gradually take that away, that swelling will go down. Yeah, absolutely. And I expect that. In fact, if it didn't, I would wonder what else was going on, right? Because I always have to remind my patients, you know, guys, some dogs have ticks and fleas. You can have 2 things. I wish it was not that way. My job would be so easy if it wasn't. But the fact of the matter is people can have 2 things. And so if it doesn't get better, even though when I think the house is clean, crystals are gone, I'm looking for something else.
Well, that's good to know. So you mentioned earlier in your talk about doing uric acid testing at home. So somebody asked,
yes,
if someone does a uric acid test at home, is there a time of day you should test?
Yeah, I'm really glad you asked that. And somebody's really smart that asked that, because they know, just like in the world of diabetes, that it matters what time you check it. The diabetic might check a blood sugar, 5 minutes after eating a donut, and it doesn't look that bad. You check 30 to 60 minutes later, and it could be a wreck, right? So time matters. So what I tell patients is, even though everybody's different, that's true, everybody's different in terms of how you process it and what food you're eating at any particular meal, but you start checking your uric acid level after about 2 to 3 hours after a meal, and write it down and make a journal. And then my patients that actually do this universally learn a lot about how their body works and how it processes uric acid, and oftentimes lots of other things about nutrition. So some patients say, well, gosh, my uric acid really peaks, like, say, 90 minutes after a meal. Other patients will say mine's about 3 to 4 hours after. Everybody's a little bit different, but it's somewhere in that neighborhood as a rule. So I encourage them to write it down and make it a science experiment at home and really try to learn how your body deals with it. But if you want to just have a starting place, about 2 hours, somewhere in there after a meal would be about right.
Okay, that's good to know. I never knew that. Thank you.
Yeah.
So here's our last question of the evening. Will having a kidney transplant lower your chance of getting gout?
I'm gonna give a short, you can tell I like thinking about this and then amplifying my answer. So I'm gonna say the answer is yes. That's the short answer, and let me amplify. I'm gonna say yes, and then amplify by saying, if the kidney transplant is successful, that's important, right? Because if the kidney transplant is unsuccessful, then you still have poor kidney function. It didn't help. But if the kidney transplant is successful, now you've got the organ back in your body that really lowers uric acid, right? And so I have patients in my clinic that once they did get their kidney transplant and it was successful, meaning the kidney function worked, the transplant's working great, I check the uric acid levels and they're great. They're between 2 and 6. They're in the sweet spot and we go on down the road. They don't need medicines to lower uric acid anymore, right? We end up tapering those all the way off. But here's the thing that I do for these patients to make sure that they sleep good at night, and so do I. I don't stop looking. I keep an eye on their uric acid over the years, just like their transplant doctor keeps an eye on their kidney function, so that if their kidney function deteriorates over time or the uric acid levels go up, you and I, me and the patient, we are on top of this before they start getting gout attacks again. Because I don't want to go back to the bad old days of gout attacks once we have it fixed up.
That's wonderful. It's so good to know. Well, thank you so much, Dr. Parker. We really appreciate your time. And this concludes.
You're absolutely welcome. Let me just tell everybody I apologize for being a little late there.
Not a problem. It was a great presentation. Thank you so much. So our next webinar will be about healthy weight pre and post-transplant. The webinar will be held on Wednesday, June 26th, and hosted by Dr. Brent Miller. Registration is now open. Visit kidneyfund.org/webinars for more information and to register. When the webinar closes, please do not close your browser window. You may see a pop-up saying that the webinar has ended. Please close that pop-up and proceed to the webinar evaluation survey. Your honest feedback will help us to make our webinar program the best it can be. Thank you so much for joining, and we hope to see you again. Bye.